Sarah Neville is from the Independent Hospital Pricing Authority, and here she comes. Encourage her down. Here's Sarah.
There we go. So, hi everyone. I'm the Director of Pricing at the Independent Hospital Pricing Authority. And I'd just like to start by thanking Gordon and the National Rural Health Alliance for the opportunity to speak today. Rural health is something that the Independent Hospital Pricing Authority is very passionate about, and we have a separate model to treat small rural hospitals, as you'll see later on in the presentation. I'd also like to thank Paul, Andrew and David for their insights so far. I've certainly gained a lot more insight into the Modified Monash model today, so we'll jump in. My presentation today is about the use of remoteness in the IHPA models, which I'll go into, and where we have tried using Modified Monash in the past. I'll show you some of the results of that. And how we intend to use Modified Monash in the future. So we'll jump in. First of all, I don't expect everyone in the room to know who the Independent Hospital Pricing Authority are, so I'll start off by just describing what we do and what our primary functions are. Then I'll describe our two major products that are the National Efficient Price and the National Efficient Cost. And both of these models incorporate a measure of remoteness in how we allocate funding to public hospitals throughout Australia. So the Independent Hospital Pricing Authority is a fairly new organisation. It was established under the National Health Reform Agreement, which is actually an anagram of the National Rural Health Alliance, back in 2011, and we were established and charged with the major function of implementing activity-based funding throughout Australia. So activity-based funding is exactly what it sounds like. We allocate funding to public hospitals throughout Australia based on the activity that they do and the volume of services that they provide. So this is based on the sheer volume of patients that go through those hospitals, but also the complexity of patients that they treat. So two hospitals of a similar size, if one of them is performing much more complex procedures that are inherently more expensive, they'll receive more funding than one that's doing providing more basic services. So the background behind this implementation of activity-based funding was to improve transparency in how the Commonwealth funds public hospitals, and also to strengthen incentives for efficiency. So the models that we implement aim to sort of spread out across all of the states and territories what we consider to be efficient hospital services, so that all states and territories can move towards a more efficient delivery of health services, of hospital services particularly. Paul spoke about the Modified Monash model as sort of incentivising the primary health workforce. IHPA is a bit different in this space in that our purpose is to focus on services delivered through hospitals. So we're not concerned with primary health at the moment and GPs. We are concerned with what happens within public hospitals. As I mentioned earlier, our two major products are the National Efficient Price and the National Efficient Cost, which I'll go into in more detail. But the basic difference is the National Efficient Price is the model that's used to allocate funding to larger hospitals that have enough activity to warrant using activity-based funding. The National Efficient Cost, which most of you would be more interested in, allocates funding to small rural hospitals that don't have the economies of scale that the larger metro hospitals have. So they have fixed costs just for keeping the doors open, so they're funded in a different way, and I'll explain that a bit later on. Just to note here, both of these models incorporate remoteness as a cost driver. So that's another thing I wanted to get across today. In case you weren't familiar with our work, remoteness is a real driving force in the allocation of hospital funding from the Commonwealth. Okay, so we'll jump in and talk about the national efficient price to begin with, which is the method we use to allocate funding to larger metro hospitals, but also larger hospitals in regional areas, be they inner or outer regional. And there's also a handful of those in the remote category. So the national efficient price is patient-centric. We look at the attributes of a patient, including what setting they were treated in, how complex the services were that were delivered to them, whether they're Indigenous or not, how old they are. But one of the key adjustments that we make within the model is remoteness. So currently in the models, we use RA, that's been discussed pretty extensively today. Patients are assigned this remoteness area using mappings from postcode, SA2 and SLA. If we don't have any of those patient level sort of remoteness characteristics, we use the hospital remoteness to assign remoteness to a patient. And currently in the model, as it has been for the past few years, patients receive a loading if they are in an outer regional, remote or very remote area. So where does Modified Monash come in? Well, IHPA is a very consultative organisation. We consult with all states and territories and other key stakeholders while we're developing the NEP, because it has such a large impact. We're determining how much Commonwealth funding should be allocated to hospitals and how that funding should be spread between LHNs and also jurisdictions. So we get a lot of feedback from these jurisdictions, and Modified Monash has come up quite a bit, so it's definitely in the forefront of people's minds. There's a bit of a split between the states and territories. Some support Modified Monash. They argue that a population-based classification is an improvement to RA. And then we have, on the other hand, the other jurisdictions think that the current system that we use, RA, better captures the cost of service delivery in remote locations. So we sort of had these competing views. A team of analysts implemented the Modified Monash model into the NEP and yielded the following results. So if you look on the left, they are the current adjustments in the NEP model. So these ones here that I'm pointing to are dependent on the RA classification. So basically, if you were comparing a similar patient, so similar characteristics, similar service being provided in a metro area versus outer regional, their costs would be around 8% higher, and that's on average throughout nationally. And then similarly for Indigenous patients are on average 4% more expensive, and then we also have remote and very remote areas, the adjustments for those areas. On the right is the updated analysis we did using Modified Monash in place of RA. And we got some interesting results. So the Indigenous adjustment remains the same as expected. 6 and 7 are the standard remote and very remote, and then we've got the split for inner and outer regional, which is Modified Monash 2 to 5. And it actually turned out that Modified Monash 2 and 3, with the larger populations, required higher adjustments than Modified Monash 4 and 5. So I guess this just illustrates that Modified Monash, that wasn't necessarily a classification that was developed to be applied at a hospital level, it's more to do with the primary health workforce, doesn't necessarily make sense in this application. In terms of performance of the model, so how well are we predicting the actual costs incurred by hospitals? So that is represented by the R-squared. They're really comparable. So because the Modified Monash is largely based on RA, this is not unexpected. And SMAPE is just a measure of error that we use at IHPA, and they're fairly consistent whether you use RA or Modified Monash. So in summary, in terms of the NEP, the costs are not necessarily more effectively explained by Modified Monash. It's pretty similar. But when we look down at a hospital level, the amount of funding that we're allocating, implementing Modified Monash had the unintended consequences of disadvantaging some small hospitals in outer regional areas. So through consultation with states and territories, we've decided to stick with the remote area classification for now. Moving on to the national efficient cost, which is the mechanism by which we allocate funding to small rural hospitals. Rather than being patient-centric like the NEP, the national efficient cost is hospital-centric. So it takes the expenditure of small rural hospitals. The majority of these NEC hospitals are small rural, so 384 out of 412. And we group and model the expenditure of these hospitals based on their volume. And volume depends on both how many patients are going through these hospitals, but also how complex are they. We also break it up by hospital type into hospitals that are providing surgical services, hospitals that provide overnight care, and then hospitals that provide day services only. And then the third metric that we use is remoteness. And at the moment that's based on RA as well. So under the NEC model, we do use RA, but for this model, we merge the inner regional, outer regional, and remote RA groups. So if you look at it in this way, implementation of RA and Modified Monash would be equivalent because we're aggregating those groups that were split out in the Modified Monash model. So this is just how we classify hospitals within the National Efficient Cost model. So here we've got those three RA categories, inner and outer regional and remote areas, and then we treat the very remote hospitals differently. We've got the three types here. So type A are hospitals that provide surgical services, type B, overnight care, and type C, day services. And then up the top, we've got the volume. So I mentioned that the volume is measured in terms of the amount of patients treated, but also the complexity. And the way that IHPA measures that is using the National Weighted Activity Unit, or the NWAU. So basically we split these 384 small rural hospitals into the groups represented here in this matrix. And we use those groups to allocate their expenditure. So just a little bit more detail about Modified Monash in the NEC. So out of the 384 hospitals in the model, 282, so the vast majority, are in the inner and outer regional RA categories. And of these, if we do split them into the Modified Monash classification, 238 are classified as MM5, and then the majority of the remaining hospitals are MM4. So as I said previously, because the current NEC model combines the inner regional, outer regional, and remote RA categories, the Modified Monash doesn't add value. It's actually equivalent to what we would do under RA. If we were to disaggregate to the Modified Monash classification, because of the majority of the block-funded hospitals falling in MM5 and the rest essentially in MM4, we sort of get the concentration of a lot of hospitals with different cost profiles being concentrated in this group. So we don't have homogeneous cost profiles between groups. So at the moment, we've had a bit of trouble sort of teasing out how we would implement the disaggregated modified Monash, but it's something we continue to look at. So in conclusion, remoteness plays a key role in both the national efficient price and the national efficient cost released by IHPA every year. We have investigated modified Monash. It's something that jurisdictions definitely have at the front of their mind, and I dare say will be suggested in the future again. But for the moment, IHPA will continue to use RA for the allocation of funding. Thanks.
Thank you, Sarah, very much.